All right, question 1 sets the stage with a classic pediatric dilemma. A child with congenital hydrocephalus has failed multiple VP shunts due to infection. The parents are, understandably frustrated, and they're asking for a long-term alternative. So what is the absolute best long-term option here?
The correct answer is E, an EVT combined with choroid plexus coagulation. Think about it. When you're dealing with a hardware issue, like a shunt that just keeps failing from persistent infections or mechanical blockages, the smartest neurosurgical move is often to just ditch the hardware entirely. This procedure bypasses the obstruction completely while actually reducing cerebrospinal fluid production right at the source.
So your big exam pearl here is that ETV is the standout, high-yield, shunt-free alternative for recurrent VP obstructions. But definitely don't forget that ventriculoatrial, ventriculopleural, and lumboperitoneal shunts are also totally valid hardware options, depending on the patient's specific anatomy and the overall clinical scenario.
Let's pivot to spinal trauma for question 2. Which of these drugs must you absolutely avoid in a patient presenting with spinal shock? We've got levodopa, isoprenaline, dobutamine, dopamine, and phenylephrine. Think about the physiological state of spinal shock here, specifically that sudden loss of sympathetic tone.
The answer is E, phenylephrine. Why? Well, phenylephrine is a pure alpha-1 agonist. It's going to spike the blood pressure by aggressively clamping down our peripheral vessels, and that triggers a reflex vagal stimulation. In a patient whose sympathetic nervous system is already totally offline, this unchecked vagal response can drastically and dangerously worsen their bradycardia. Lock these pearls in for your exam. Dopamine is your traditional pressor of choice to maintain that crucial mean arterial pressure. If you hit severe bradycardia, treat it immediately with atropine. And honestly, the primary overarching goal you can never forget in spinal shock is this: maintain adequate perfusion to save that spinal cord from devastating secondary ischemic injury.
Question 3 shifts our focus over to cranial tumors. Exactly where does a craniopharyngioma originate? Is it the olfactory bulb, Rathke's pouch, Rathke's cleft, or Rathke's cyst? This is one of those pure embryology recall questions that just shows up time and time again.
The answer is B. These tumors derive directly from the embryological remnants of Rathke's pouch. And as a quick refresher, that's the precursor to the anterior pituitary gland.
What's really fascinating here is the classic triad you absolutely need to memorize. First, you'll almost always see calcification on imaging. Second, if the cyst is aspirated, the fluid classically contains cholesterol crystals. It's often described as looking exactly like machine oil. And third, because it sits right above the pituitary, the clinical presentation frequently gives you bitemporal hemianopia alongside endocrine dysfunction.
Moving on to question 4. What familial syndrome is most commonly associated with meningiomas? If a patient walks into your clinic with multiple meningiomas, your mind needs to immediately jump to one specific genetic condition.
The answer is NF2. Now, it is incredibly easy to mix up the neurofibromatosis types in the heat of an exam, but you've got to keep this distinction strict. NF1 primarily means neurofibromas, whereas NF2 classically delivers this very specific package of bilateral vestibular schwannomas and multiple meningiomas.
Hitting visual defects for question 5. A patient has homonymous hemianopia, meaning they've lost the exact same half of the visual field in both eyes, but with central macular sparing, so their central high-resolution vision is actually perfectly intact. This specific pattern pinpoints a lesion exactly where.
The correct answer is D, the occipital lobe. And the reason for this beautiful anatomical quirk is that the macular representation, sitting at the very back of the occipital pole, gets a dual blood supply. It receives flow from both the posterior cerebral artery, or PCA, and the middle cerebral artery, the MCA. So if the PCA goes down, the MCA seamlessly steps up to the plate and spares that central vision.
Let's map out these visual field defects to build a quick shortcut memory tool. This is pure gold for fast test taking. Pituitary or chasm lesions, that means bitemporal hemianopia. A temporal lobe lesion hitting Meyer's loop gives you an upper quadrantinopia, famously known as pie in the sky. A parietal lobe lesion yields a lower quadrantinopia, or pie on the floor. And an occipital lobe lesion gives you that homonymous hemianopia that distinctively spares the macula.
All right, let's apply those principles. Question 6. An unconscious woman with acromegalic features, so think large hands, coarse facial features, suddenly develops a retroorbital headache and severe visual loss. What is the most likely diagnosis?
The diagnosis is A, pituitary apoplexy. Those acromegalic features, they tell you right off the bat that she already had a growth hormone-secreting pituitary adenoma. The sudden headache and visual loss tell you that the adenoma just acutely hemorrhaged or infarcted. It's rapidly expanding and severely compressing the optic chiasm.
Lock these pearls in. MRI is your absolute gold standard for imaging here. Immediate IV fluids and high-dose steroids are your critical first steps. Why steroids? Well, ACTH deficiency is the fatal hormonal drop you have to anticipate. Without it, the patient plummets into an acute adrenal crisis. And you only proceed to transsphenoidal surgery if those visual deficits are progressively worsening despite your medical management.
Question 7 is keeping us right in the cellar region. A 15-year-old girl presents with galactorrhea and a negative pregnancy test. We are obviously thinking about a prolactinoma here. So, given that diagnosis, what visual finding is most commonly associated?
The answer is bitemporal hemianopsia caused by that upward expansion compressing the optic chiasm. The massive takeaway here is that your first-line treatment for a prolactinoma, even a huge one causing visual field defects, is always medical therapy. We're talking dopamine agonists like cabergoline or bromocriptine. These tumors basically melt away with medication, so you reserve surgery strictly for medical failures or totally intolerable side effects.
Final question, and it is a critical emergency scenario. A laborer gets a sudden, severe headache, vomiting, and altered consciousness while lifting a heavy object. That physical exertion is a major clue here. What is your absolute most immediate investigation?
The answer is B, a CT scan without contrast. When you perform this on day 1, it's around 95% sensitive. That makes it the fastest and most reliable way to spot a subarachnoid hemorrhage, which is typically going to show up as bright white blood pooling right there in the basal cisterns.
Your algorithm here is vital for both the wards and the boards. A sudden thunderclap headache equals a subarachnoid hemorrhage until proven otherwise. Always start with a non-contrast CT. But, and this is highly tested, if that CT comes back perfectly clear, yet your clinical suspicion is still high, you must immediately perform a lumbar puncture to hunt for xanthochromia, which is that yellow breakdown product of red blood cells. Only after you confirm the bleed do you order a CTA to hunt down the ruptured berry aneurysm.
Let's do a rapid revision to finish up and really cement these concepts. Failed VP shunts equal ETV. Avoid phenylephrine in spinal shock to prevent catastrophic bradycardia. Craniopharyngiomas originate from Rathke's pouch. Meningiomas are classically tied to NF2. Macular sparing points straight to the occipital lobe. Acromegaly paired with a sudden headache is pituitary apoplexy. And a thunderclap headache absolutely demands a non-contrast CT first. We've explored the rationale and the exact pearls you need to conquer these topics. Now, if you see a pie-in-the-sky visual defect on your next exam, will you immediately know which lobe is damaged? Keep that focused mindset, and I'll catch you in the next explainer.